Once we go live, I see only 5 participants.
Dr. 3, 2, 1, go ahead.
Once we go live, I see. All right. Just wait for a few seconds until the attendees number catch up. All right. Well, Bismillah ar-Rahman ar-Rahim. On behalf of the Saudi Society of Blood and Marrow Transplant, I would like to welcome all attendees to the weekly webinar of the SSBMT. Today's webinar is sponsored by Amgen. I would like to thank Amgen for sponsoring this webinar tonight. And it is going to be focused on ASH updates of in multiple myeloma. Our guest speaker is well known to everyone, I guess. He needs no introduction. It's Dr. Saad Osmani. Dr. Saad Osmani, he's the division chief of Plasma Cell Disorders Division, and he's the director of Clinical Research in Hematologic Malignancies, Department of Hematologic Oncology and Blood Disorders at Levine Cancer Institute, Charlotte, North Carolina, in the United States of America. So as I said, it's going to be focused on multiple myeloma updates from the last ASH. Please, for the attendees, you can post your questions in the Q&A session. And at the end of the talk, we will answer them one by one. With this, I would like to ask Dr. Saad to go ahead with his presentation. Dr. Saad, thank you.
Thank you so much, Dr. Ayman, for your kind invitation and for moderating this webinar series. I'm going to try to share my slides. All right.
All right, we can see them.
Okay. And are you able to see the full screen?
Yes, go ahead.
Okay, wonderful. All right, so, there were a lot of updates at ASH just a few months ago, and it's hard to imagine that we are already nearing the end of the month of March, and, Ramadan will be not so far behind. To start off the presentation, I'll share this disclaimer that the presentation does contain information about products and indications that may not hold a marketing authorization in Saudi Arabia, and to check with the current Amgen representatives for the approval status of those products inside Saudi Arabia. And then from the Amgen sponsorship perspective, Amgen does not recommend the use of its product outside the approved indication. So having said that, I will get into the meats and potatoes of the talk here. These are my disclosures. What I'll try to do is give an update on the CAR T cell therapies in multiple myeloma. There were several constructs that were presented. I will also try to update on the emerging bispecific antibodies as well as antibody drug conjugate data. And then in the end, I will also give updates on the Candor trial data because there were updates on survival outcomes as well as depth of response compared to the original presentation. All of you are familiar with the concept of chimeric antigen T-cell receptor therapy. Essentially, these are autologous T cells that are apheresed from patients. And then the chimeric antigen receptor, which has been designed specifically against a known tumor antigen, is introduced into the T cell. And this is done outside, kind of an ex vivo kind of a process. After that initial expansion, the product is sent back to the transplant center from the sponsor, or in case of homegrown GMP facility CARs, they're done within the institution. Whenever the product is ready, within a certain period of time, usually about 3 weeks or so, patients undergo lymphodepleting chemotherapy, and then the CAR Ts are infused. You can see from this particular figure, BCMA, it has been a preferred target for the initial CAR T cells, and that have been, looked at for multiple myeloma. But there are other targets that are being evaluated in early phase clinical trial, and there is preclinical data that exists with them as well. But the concept is, once you have primed these T cells to recognize antigens, it results in T cell activation, degranulation, and tumor cell lysis. So with that concept in mind, I'm going to be sharing information about mostly BCMA CAR Ts, but then there are others that are coming down the pike, and you'll get to hear about them later in the year at ASH, and probably more mature data from those early studies in the coming years. This is a very busy table, but puts everything in good perspective. And I'll try to walk you through this table from the left side of your screen to the right side of your screen. So in the first column, you see that I've divided each of these studies with characteristics around the number of patients, median prior lines of treatment, whether they were triple class refractory to PIs, IMiDs, or anti-CD38 monoclonal antibodies, the CAR T cell dose that was given, the overall response rate, CR or stringent CR rates, then cytokine release syndrome, all grade 3 or 4. Then the same thing for neurotoxicity, all grades, and then grade 3 or 4. And now, I'll walk you through the subsequent columns. So the first column is for the cilta-cel construct, which is a Janssen CAR T directed towards BCMA. And the study is the initial CARTITUDE-1 study, which had enrolled 97 patients. So it was a phase 1b/2 study. 6 median prior lines of treatment, over 87% of the patients had triple class refractory disease. The CAR T cell dose was a bit lower because this particular construct targets 2 different epitopes of BCMA, and apparently needs a lower CAR T cell dose infused, and it expands in vivo in the patient. All of us were very impressed with the overall response rate of about 97%. 67% of the patients had a CR or stringent CR. Almost every patient got all grade CRS, but grade 3 or 4 was seen in only about 4% of the patients. Vast majority of patients got tocilizumab or corticosteroids to support them through. Neurotoxicity was observed in about 20.6% of the patients, with grade 3 or 4 being 10.3%. And you have this early neurotoxicity and then a late neurotoxicity with this particular product. The early neurotoxicity is what we are used to seeing with CD19s or even ide-cel that I'm going to talk about briefly. But the late neurotoxicity that is observed is in some patients, and it's self-limiting, is movement kind of disorders or Parkinsonian kind of picture that gets better with supportive care measures. But that's a bit of a unique kind of neurotoxicity that has been observed. Then the second column here is ide-cel, which is the CAR T that is farthest along and we have the most clinical experience with. But this particular study, the CRB401, was the original phase 1. that had included 62 patients, very similar kind of a patient population. But this was a dose escalation study starting with a dose of 50 million CAR T cells, 150, 450, and 800. And in this study, overall, the response rate was about 76%, with CR or stringent CR rate of about 39%. And you can see the pattern of CRS appears to be similar. Now, there are differences between these two CAR Ts. With cilta-cel, you get CRS at a median of about 5 or 6 days. With ida-cel, you get it within the first 48 hours for the most part. So how we're going to manage these patients, whether inpatient or outpatient, there are going to be a few differences. Now, the third column is BB21217, which is a very similar construct to the ida-cel construct, but in that particular construct, the cells are expanded with a PI3 kinase inhibitor, pushing them towards more of a memory phenotype. And these are early data. With that particular product, we see similar kind of overall response rate compared to ida-cel, but we're not sure about the durability of the response because there's not enough follow-up with that. The idea of pushing the CAR Ts towards a memory phenotype is to make them last longer. So we're going to, efficacy seems to be the same, but how long does that efficacy last? We don't know. So we'll find out more. Then we have, in the fourth and fifth column, two very interesting kind of constructs with the LumiCAR construct that my colleague Dr. Shaji Kumar presented. But it's early data, only 20 patients, but lower CAR T cell dose, or rather similar CAR T cell dose to ida-cel. Response rates are good, but the grade 3 or 4 CRS appears to be low because the use of TOCI was quite early in this particular patient population, but appears to be safe and quite effective. The prime BCMA 101 is a very interesting concept. This is a transposon-based technology with a kill switch. So the CAR Ts are infused, they do their job, and they go away very quickly. And the likelihood of getting high-grade CRS or even all-grade CRS is good. You can see the safety profile here is very different from cilta-cel, ida-cel, or the LumiCAR product. But the efficacy, the overall response rate appears to be a bit lower. So you're kind of balancing safety versus efficacy here. And then lastly, there was a construct of combined dual CAR T targeting BCMA CD19. Very early data, and responses appear to be good. But these data came from our Chinese colleagues, where the access of drug is a bit different. So we don't have good data about the triple class refractory status. All right. Having said that, I'll move on to the other salient features that we learned. One of the questions we keep on asking ourselves is, okay, what happens to the high-risk patients who have extramedullary disease or high-risk cytogenetics or high level of tumor burden? What kind of responses are we getting in those patients? And this particular abstract that Dr. Nupur Raje presented showed that for at least those three particular populations, the overall response rates were a bit similar compared to those patients who do not have those features. So EMD patients responded, patients with high-risk cytogenetics responded. And then, she also looked at, how quickly were the patients progressing through different lines of treatment. So less than one versus more than one. And sure, if a patient had less than one prior line of treatment in the last year before coming on to the protocol, they had a higher overall response rate. But even the response rate in patients who had more than one prior line of treatment in that last year before enrolling on study was about 65%. So not bad. Another important thing that was highlighted, again, I'm going to a different construct here. So with the cilta-cel construct, was the symptoms before and after treatment with cilta-cel. One of the advantages of CAR T cell therapy is, you it's a one and done kind of an approach. Patients are not on any maintenance treatment after CAR Ts. And what we found in this follow-up that Adam Cohen presented on the quality of life is that the bone pain, fatigue, likelihood of fractures, GI issues, neuropathy, and weakness, all of those things get better because patients are not taking any treatment. So, this is an important advantage of CAR T cell therapy. Even in this late stage where patients, we have to keep them on something to keep the disease controlled. With CAR T cell therapy, that's one particular advantage. And then, looking at the patients reported on the HRQOL specific items, in terms of their improvement in relationships, emotional, psychological functions, activity of daily life, all of those things continue to get better for vast majority of patients. And you can see the comments that the patients made. So by the time they're 6 months out from CAR Ts, having not been off of treatments, they're getting back to their activities of daily life. They're being off of treatment. They feel that it's kind of a blessing from that perspective. All right, a very interesting concept is, all right, you're taking CAR Ts right now from patients, you're apheresing the autologous T cells, but what if you can utilize an allogenic donor? That will become an off-the-shelf product. You can have one donor and create 100 products. And they're right there. If a patient comes to you and they're about to, they're having a relapse, you don't have to wait for, 4 or 6 weeks to get the CAR T cell and worry about, okay, what I'm going to do with this patient right now in front of me. You can essentially, get this off-the-shelf product, start lymphodepleting chemotherapy next week, and give them the CAR T in the outpatient setting. So with this concept in mind, the Allogene company presented their data on their anti-BCMA Allo CAR T called LO715. The way they've done this is by knocking off the T cell receptor to minimize GVHD. And then, for the T cells that have they have CD52 to prevent graft rejection, they're giving anti-CD58 antibody called LO647. So this is a phase 1 open label, multi-center dose escalation study. The cool thing about this is about 90% of the patients treated were able to get their CAR T within 5 days of enrollment. That's pretty cool compared to the vein-to-vein time of about 29 days with ide-cel or with cilta-cel. And I think this is the future. You're going to hear a lot more about the allo CARs moving forward. And these are early data. This is only a dose escalation study, but what we're finding is, in the 10 patients that were response evaluable, they had 6 of them responding, with 4 out of 10 having a VGPR or better. Again, early data, this study is still in dose escalation, so we'll get to learn more about this. The bottom line from ASH was that all patients that were treated on these CAR T cell therapies were heavily pretreated, some having received an average of 6 or more prior lines of treatment, vast majority being triple class refractory. And they had varying degrees of the same kind of side effects of CRS, neurotoxicity, and blood count issues. And most patients responded very well to treatment. So very promising kind of phase we're seeing with these CAR T cell therapies. And I think the allo CARs are where the field is probably going to move. What's the role of CAR T cell therapy in the treatment landscape? I think the important aspects for us are going to be the vein-to-vein time. I highlighted high risk in EMD. We're seeing even in those patients, we're seeing high levels of overall response rate. Durability appears to be the same. We have the most follow-up with ide-cel, but I suspect we'll see similar data with cilta-cel. And then the safety profile is what will distinguish one over the other. And then how do you differentiate the CAR T cell therapy from other BCMA targeted therapies? That the the advantage is no maintenance and good quality of life. That's what I've highlighted with some of the data that I've shared. The disadvantage is production time and capacity at transplant centers. And this is where, the allo CAR concept is going to come into play. And, what will be the optimal place for CAR T cell therapy in the changing clinical algorithm? I think the initial CARs are going to be approved in the late relapse setting in the United States and the rest of the world. The capacity at transplant centers, the availability of or access for those patients, and then eventually the cost, that's going to play a big role in how we're able to incorporate this particular strategy into the clinical algorithm. I think it would be most useful for high-risk patients. And that's where we're already starting to evaluate in the frontline setting. Now coming to the bispecific antibodies and the bispecific T-cell engagers. So the bispecific T-cell engagers are kind of like under the umbrella of bispecific antibodies. With bispecific antibodies, you have the whole antibody. One part of the antibody is recognizing the antigen on the surface of the cancer cell. In this case, it's BCMA. The other part is recognizing CD3, and it's bringing the T-cell activation happens, and the T cell kills the myeloma cell. With the T cell engager technology, it's a partial antibody, so it's not the whole antibody, and it's really doing the same thing. One part of the T cell engager attaches to the myeloma cell, the other one to the T cell, and both of them lead to myeloma cell death. So we heard data about the AMG 701 product. So this is a bispecific T-cell engager. This is a phase 1 study that has enrolling 85 patients with a median age of 64 years, 6 median prior lines of treatment. And the overall response rate, in this patient population at the maximal tolerated dose right now was 83%. For the overall patient population, the response rate was somewhere around 50-odd%. Maybe a little bit higher. So as the study moves forward and we have a higher percentage of patients, higher, those expansion cohorts, we'll see what the true overall response rate will be for that for this particular bispecific. It's given on a weekly basis, and it's an half-life extended compared to the AMG 420, which is no longer moving forward in clinical development. Then we have, teclistamab, which was originally, I reported these data at ASCO last year, and my colleague, Dr. Garpal, updated them at ASH. This study includes both a dose escalation IV cohort and then eventually a sub-Q cohort. You can see the big advantage with these bispecifics is the low grade of CRS. About at the recommended phase 2 dose with the subcutaneous formulation, and the CRS is about 64%, and it's all grade 1 or 2. And the overall response rates are 73% at that subcutaneous dose given at 1500 microgram per kilogram in triple class exposed or refractory patients. The sub-Q dosing is the distinguishing attribute here, and this too gets given on a weekly basis. So very promising response rates that you see here with both these bispecifics. And then Regeneron is the next BCMA bispecific. These data were presented by Deepu Madhuri. Similar kind of CRS grading, grade 1 or 2 across the different cohorts. You can see that this particular study is a little further behind compared to AMG 701 and teclistamab, but response rates in the highest dose group are quite impressive, with VGPR or high rates of 95% in a heavily pretreated patient population. So their dose escalation is continually ongoing, and we'll see what these data look like, as they mature. I was most excited about the next two bispecifics because they're targeting not BCMA, but other things. So the bispecific antibody that is targeting GPRC5D. So this was a phase one presented by Ajay Chari. And this it has been a slow dose escalation expansion study demonstrating, and this too is being given in as a sub-Q, showing at the a recommended phase two dose of 405 microgram per kilogram. The overall response rate is 69%, with 39% of the patients having a VGPR or better. And this is a heavily pretreated patient population. Some patients on this study actually had prior BCMA exposure and even BCMA CAR-Ts as well. Same story for this one, cevostamab. This is a BCMA bispecific T-cell engager that is targeting FcRH5L. This is an early dose escalation study. They have treated 53 patients so far, but in the highest cohort, they're seeing an overall response rate of 53%. So, very encouraging data with these bispecific technologies, specifically the last two bispecifics that I've shared with you. Then going to the antibody drug conjugates, we're all familiar with the belantamab mafodotin antibody drug conjugate data that was shared and published last year by my colleagues Sagar Lonial, showing that in the two different dose cohorts of 2.5 milligram per kilogram given every 3 weeks and 3.4 milligram per kilogram given every 3 weeks, an overall response rate of 32% and 35% respectively. The side effect profile, is quite unique. There is a particular keratopathy that tends to happen because of the drug conjugate part of this antibody. The responses are comparable between the high risk and the standard risk patients. So this is already FDA approved, and they did not report any change in the safety data. The median overall survival estimates are 14 plus months with belantamab mafodotin. So very, it's an active drug, unique side effect profile, but it's available in the clinic, and ongoing studies are looking at combination of belantamab with other IMiDs and PIs and even antibodies. There was a new antibody drug conjugate that was presented by my colleague Shaji Kumar at ASH. It's MedImmune or Medi2228, and it appears to be quite active with an overall response rate of 66%. This again was a dose escalation study with a dose expansion cohort at the 0.14 milligram per kilogram dose. This too is being given on an every 3-week basis. And there is a peculiar ocular toxicity with this therapy as well. It's not keratopathy, it's corneal, it's more conjunctival irritation and redness that occurs, very different from the keratopathy that's seen with belantamab mafodotin. And the other side effect, beyond the photophobia, is this peculiar pleural effusion that patients develop. Some actually requiring hospitalization, as well as thoracentesis as well. So different kind of side effect profile, but this ADC is also making its way into the clinic with very high overall response rate reported with this phase one. So, if I were to summarize everything that we've talked about so far, CAR-Ts and T-cell engaging antibodies represent a new wave of myeloma therapies that are very active, even in heavily pretreated patients. Toxicities of CAR-Ts and T-cell engagers and bispecific antibodies mainly consist of cytokine release syndrome, immune effector cell-associated neurotoxicity syndrome, or ICANS, low blood counts, all of which are treatable. And treatment targeted at GPRC5D and FcRH5 are the new targets, and they're showing efficacy. And then we have BCMA-directed antibodies, drug conjugates, both belamaf, that's FDA approved, and Medi2228, that's in clinical development. They both have ocular toxicity, but they appear to be different ocular toxicities. So, having summarized all these data, I'm going to move into some updates on the CANDOR study. And to remind everyone what the CANDOR trial was, this was a randomized phase 3 trial with a 2-to-1 randomization in relapsed refractory multiple myeloma patients who had 1 to 3 prior lines of treatment. And they had to have a PR or better in at least one prior treatment line. Total of 466 patients were randomized in a 2-to-1 fashion to receiving either carfilzomib, dexamethasone, and daratumumab, or carfilzomib and dexamethasone. Carfilzomib was given at a dose of 56 milligram per meter squared, days 1 to 8, 9, 15, 16. Dexamethasone was given at 40 milligrams for older patients 75 or older. It was 20 milligrams, and daratumumab was given as a split dose for the first 2 doses at 8 milligram per kilogram IV. Subsequently, on a weekly basis for the first 2 cycles, every 2 weeks, cycles 3 to 6, and then every 4 weeks, similar to how we give data in our clinics. The primary endpoint was PFS. Secondary endpoints were overall survival, overall response rates of CR or better, safety. MRD was also an important secondary endpoint. So my colleague, Dr. Demopoulos, updated the study with a median follow-up of about 27 to 28 months, showing that the median PFS in the dara-KD arm was 27.8 months, 28.6 months compared to 15.2 months, with a hazard ratio of 0.59. So these data were presented as a late-breaking abstract at ASH in 2019, and with a subsequent, roughly 11-month further follow-up, that's the median PFS that has been reached for this particular study. What's important to note in this study is if we look at PFS according to prior lines of treatment, prior refractoriness to proteasome inhibitors, exposure to lenalidomide or refractoriness to lenalidomide, all of those are favoring dara-KD. Particularly for the len refractory patients, the median PFS that has been observed with dara-KD was, or KD-dara was 28.1 months with a hazard ratio of 0.46. If we break it down further by 1 prior line of treatment or 2 or more prior line of treatment, if you pay attention to the median PFS, I don't know why the right side of my figure is not showing up the way that it should, but the median PFS data is right there for all of you to see. In 1 median prior line of treatment, patients with refractoriness to len or exposure, 25 months of PFS compared to 11.1 and 9.3 respectively, and not reached for len naive patients, and then 2 or more prior line of treatment for len refractory and exposed patients, 28.1 months of PFS compared to 12 months, which is very encouraging for that patient population. Safety profile wise, higher grades of 3 or grade 3 or higher overall adverse events, and the fatal events 8.8 versus 4.6. Of the fatal events, 1 fatal event in the KD data was due to arrhythmia, and 1 fatal event in the KD due to COVID-19 pneumonia. The rest have already been shared in the primary paper that was published, and we've just submitted the updated manuscript from these data for review at a high tier journal. So you'll have that data in the public domain as well. And if you adjust the AE rates per 100 patient years, the fatal grade 3 or grade 5 events is 6.9 versus 5.6%. If we start breaking things down by response rate by relapse group in patients with 1 prior line of treatment, there is a so you're trying to distinguish early versus late relapsers here. You find that the efficacy holds true in both those groups. either by early or late relapses. Same holds true for patients who had 2 or more prior lines of treatment by early versus late relapse. If you look at the bortezomib or ixazomib refractoriness, the same holds true in favor of KD Dara or Dara KD, whatever you want to call the regimen. MRD negativity rates too are higher, whether you look at best overall MRD negativity at any time, MRD negativity at 12-month mark, MRD negative CRs at any time, or MRD negative CR rates at the 12-month mark. Regardless of how you cut this pie, you find that the depth of response and MRD negativity appears to be higher in the 3-drug combination. And this goes along with the theme that we've seen with other studies, the Pollux trial and the Castor trial as well. Specifically, if we look at the depth of response at MRD level at 12 months versus depth of response, relative to KD, you find that more patients have 10 to the minus 5 or higher than 10 to the minus 5 depth of response in the KD data arm compared to the KD arm. So yes, you have patients who have good depth of response with KD, but the deeper responses are actually seen in the 3-drug combination arm rather than the 2-drug combination arm. So if I were to summarize, then the data from Candor that was presented, there was a lot of different analyses done with approximately 27-month follow-up. The median PFS with KD data was 28.6 months versus 15.2 with KD. We did not see any new safety signals. The survival outcomes with prior LEN exposure was favorable for the 3-drug combination as well. Probably the most promising results we've seen in the LEN refractory patients compared to the other combinations. So speaking to the anti-CD38 carfilzomib dex combination in that space, MRD negativity rates were higher, MRD negative CR rates, with a further follow-up of 6 months, was higher, and none of those patients who are MRD negative CR have progressed. And then, I think KD Dara or Dara KD is an effective regimen for this patient population, particularly, at least in our practice, we favor this for the LEN refractory patients with the caveat, that you have to look at the patient profile from a cardiovascular standpoint, as well as, for older patients, perhaps other options may be better. So, how do we define LEN refractory patients? These were some of the questions that have been posed to me in the past. By the IMWG working group criteria, refractoriness to a drug is defined by progressing while on a drug or within 60 days of being off that drug. Typically, we would think of LEN 10 milligrams or higher as that, as being LEN refractory, because that's how it's been defined and done in studies. There are always exceptions, and we all have those exceptional, image responders. But that's an exception and typically not the rule. And then, how do we mitigate infection risk for relapse refractory patients? For patients who have recurrent infections and hypogammaglobulinemia, we may use prophylactic antimicrobials or IVIG, especially for upper or lower respiratory tract infections during winter months. That's something that we would typically do in our practice. And can we use, KD Dara or Dara KD, again, whichever one you want to call it, in older patients? I have to say that you have to do this with, using your clinical acumen with no limited cardiovascular risk factors, for example. And then you always use dose attenuation with geriatric assessment tools at hand. So that's what we do in our practice. I can share with you that I have used KD Dara in a dose attenuated fashion, not the clinical trial fashion, in some patients who are in their 80s as well. And typically after getting a certain response, I take them off, one of the drugs and just keep them on monthly data or something like that. So I've done something, with different with this regimen for older patients. We are always improvising, for these kind of situations. All right, I believe this was my last slide. At the end, I always like to acknowledge, the team here at Levine. This is after the ASH 2019 meeting. It's not during the COVID pandemic. And I hope that we can get back to seeing each other together and hosting, meetings and having these in-person meetings. Thank you for being patient listeners, and I'll be happy to hand over things to Dr. Ayman and take any questions.
Well, thank you very much, Dr. Saad, for this elegant presentation. Very nice highlights about what happened in ASH last year. If I may ask all participants, if you have any question, please post it in the Q&A session, and we will address it as it comes. Dr. Saad, I mean, I've seen that in these CAR-T, although the data are not mature enough, but from people who have participated in trials and some of the updates, that the median PFS is around 8 months. With this in mind, and looking at the bispecific molecules, which are easier to use, it's just a drug, although they are both sharing the same concept of using T cells to engage and act on the malignant plasma cells, and more or less have similar side effects because of the mechanism of action. Now, and the CAR T cell therapy mandates, lymphodepletion therapy, then 2 weeks waiting for the expansion and transfection and expansion, and then reinfusion. The cost is very high with the CAR T cells also. I mean, looking at all of these aspects, what do you think? I mean, of somebody like me who thinks that why do we use CAR T cells now, since we have all of these data, and probably bispecific molecules are going to be more or less similar, even better probably. What do you think?
So I think that will be. I actually echo exactly what people are saying. If the bispecifics, the big advantage with bispecifics is, you can give the patient a bispecific the next day after seeing them, if they're giving the same kind of efficacy, then being the off-the-shelf option would be a very reasonable approach. And you can potentially even combine one bispecific with another antibody or another drug and even deepen the response. And those trials are going on right now. I don't think that in the long run the cost will be any different. I think the bispecifics are not going to be cheap therapies either. And the fact that you'll have to keep on giving them, once a week or every other week, to keep the disease under check, is something that will come up from a cost perspective as well as from the patient's perspective. And you're right. I mean, the CAR T cell therapies do require a lot of early investment, both financial as well as toxicity wise, from the patient. And resource-wise from the cancer center or the transplant center, but then the downstream thing is patients are not on anything afterwards. So I think there will be value to both, but it's early to say how we are going to be picking patients for those strategies. For the auto CAR-Ts, cilta-cel, I have to say that the 12-month PFS was 76%. That was reported at ASH. So, which means that the median PFS will likely be 18 plus months for that product, compared to ide-cel, where it's been reported at 8.8 months because of the follow-up. So maybe, we might go for one product preferentially because it's giving a better median PFS compared to the other. But those are just general thoughts. I mean, we're going to be having this conversation, Ayman, for the next, 1-2 years.
Yeah, you're right. One thing also about the Candor trial, I mean, definitely this regimen have shown the best progression-free survival in patients who are LAM refractory, comparing to Optimism, Castor even, and the Icaria with acetoxinib. But how do you see the IKEMA? I mean, I'm not asking really to compare Candor to IKEMA, but how would you see the combination of isatuximab with carfilzomib and dexamethasone in comparison to DARA KD? Would you expect similar? I mean, there is no, I'm not aware if there is a median PFS yet. It's not reached even in the last update. But how do you see these two, comparing them to each other? Would you say similar or?
Yes, so I would say that the way I would say this is anti-CD38 plus KD combination appears to be similar in both the trials. And then anti-CD38 antibody plus pomalidomide dex combinations appear to be similar as well. So yes, there is synergy, but both are comparable. In our experience, we cannot rescue a patient who has progressed on DARA with isatuximab and vice versa. So my impression is that they work in a similar fashion, and it's difficult to salvage a patient with one antibody when they have already progressed on the other. Um, you know, at the end, at least in the United States, it becomes, a cost issue. And, many of the healthcare systems or insurances may favor one antibody versus the other because of cost. At least now, the other advantage with daratumumab specifically is the subcutaneous formulation and the convenience that it has given in the US. But if isatuximab comes in with a subcutaneous formulation, then again, it will become more of a financial question for hospitals and for insurance companies. Activity-wise, they appear very similar.
Right, we have a few questions here posted. I mean, the first one is, would you consider KRD in patients who have previously been exposed to either of the drugs, like lenalidomide or carfilzomib?
I would, as long as they have not had that exposure in, say, the last 6 months or so, maybe longer. For newly diagnosed patients, typically we would not be using, if we use KRD for induction, we would only be using one of the drugs for maintenance. So, the patient would be K exposed, but not K refractory. The story with LEN will be different. If you've discontinued LEN, typically I would say, if it's beyond 6 months, it won't be unreasonable to use KRD.
Yeah, I mean, I really find it sometimes, I mean, in even LEN refractory patients, or when they are refractory to the 10 milligram, although this is not the best recommendation, I would say. I mean, when you combine it with other drugs like in KRD or DARA-RD, you will really find synergism between these drugs and have an efficacy out of the lenalidomide, although when it was alone, it wasn't really that much efficacious. Do you have the same experience, or you would say otherwise?
No, I do. I do agree. If you combine LEN with something, with a mechanism of action or drug that the patient has not seen before, going from 10 milligrams to the full dose, you would get a response and efficacy. but it wouldn't be the same expectation as someone who is len naive. You won't get the same benefit. It will be shorter than that. That's been our impression. And before we had all these mechanisms of actions, that's what we did. We tried to escalate the dose of len and add something else. But the mileage we get from that would not be the same that's been reported on the Aspire trial. We won't get 27 months. We might be able to get 10, 12 months, but it won't be the same.
Right. Another question about clinical trials. In Saudi Arabia. Do you have any suggestions on how can we give our patients access to new clinical trials using new agents like the bispecific and ADCs?
I would say that, well, we can certainly push the pharma colleagues together to try to get those kind of options to the patients and colleagues in Saudi Arabia. And the other potential way would be to build collaborative bridges, between institutions and see what can be done together. But you would know the situation in Saudi Arabia much better than me, Dr. Ayman.
Yeah, I guess we have to encourage, companies to put Saudi Arabia in the radar and have it, participate in these clinical trials. Otherwise, compassionate use programs can be a way to access certain drugs, but definitely not CAR T-cell therapy. The next question is about CAR T and allo transplant in myeloma. Although allotransplant is not really famous in myeloma, or not the therapeutic option that many would use. But the question is, do you think that CAR T-cell therapy will replace allotransplant?
I guess, CAR T-cell therapy is easier to give than the allo transplant. It may supersede an allo in certain situations. I would not discount, even though allo is not popular in myeloma, there are instances where we still use it for young patients with high-risk disease. So, I wouldn't, I'm not a big allogenic stem cell transplant fan for myeloma, but
no one probably is.
Yeah, but we still think about that option for certain situations. So CAR T would be favored. I wouldn't say that it will throw out allo altogether.
All right. I guess we have one more question. It's from Dr. Badal Gohari. So she's asking about the comparison of data and istoximab. So she's saying, what do you think about the less side effects as regards to pulmonary infections with isatuximab compared to DARA?
So in our experience, it's been about the same, and we've done clinical trials with both, and you might see differences in percentage when you're looking at different clinical trials, but you always have to look at it's difficult to do a cross trial comparison, but it's important to look at the control arm versus the experimental arm. And if you look at that pattern, it's very similar. And that's exactly what we see in the clinic as well when we use both these antibodies. They're targeting the same thing. It's anti-CD38. It affects, the effector immune function. It increases the risk of, upper and lower respiratory tract infections in both scenarios. So, and the drugs that we use, if we're using a proteasome inhibitor with each of these therapies, proteasome inhibition too, causes an increase in infection. So the pattern is kind of similar.
Yeah, so we're approaching the end of our time, but just one last question. What do you think about the at least the first antibody drug conjugate that got approved by FDA, belantamab mafodotin. I don't know about your experience. I mean, do you think any patient population would be the most suitable for this drug? Those who have been refractory to many of the agents that are available now. Any specific group of patients? Would you not give it to any specific group of patients? What do you think?
I guess, for patients who may be eligible for bispecific or CAR T cell therapies, I would favor those over the antibody drug conjugate. And then, for older patients, you can give belamaf less frequently. So you don't have to give it every 3 weeks. You can give it every 4 or every 5 or every 6 weeks. It's an active drug, and you'll know within a couple of months if it's working. If your patient is going to be in that 35%, 35%. And if it's responding, patient is responding, you can try to space out the dosing so that patients don't develop that keratopathy. And it's also convenient from a patient's perspective that they just, they're not taking any pills. They're just coming in for, one infusion every several weeks or so.
Any combinations with this drug?
Right now, there are combinations with pomalidomide, with Revlimid, and even RVD in the frontline setting. So we're doing a phase 1 right now. It's called DREAM9, where for transplant ineligible patients, we are giving belamaf with RD or RVD. So that trial is ongoing, and we'll hopefully have some data either later this year or early next year.
One more question just came up. Sorry, I mean, it's going to be the last question. So it's again allo-SCT, allo-transplant. I mean, if you get a patient who is in his 30s, for example, with a very bad disease like 17p deletion, you consider allo?
I have. I mean, I've done allos for those kind of patients myself. If I had the option of putting them on a clinical trial, I would favor that, over an allo in that scenario, because the allo will still be there as an option for them if the clinical trial doesn't work for them. But certainly, I've taken care of exactly that kind of a patient where we did a planned auto allo. Someone who had biallelic deletion of p53, had extramedullary disease, young patient, and we went that route. But again, that's an exception, right? So
you're right. I mean, still allo really is not really being visited a lot in myeloma. Well, we're coming to the end of our webinar tonight, and before I conclude, I would like to thank you very much, Dr. Saad, for your presentation and the discussion that we had. Thank you very much. And again, on behalf of SSBMT, would like to thank the attendees for staying with us until now. And with this, I conclude the webinar for tonight. Thank you and goodbye. So just a word about our next webinar next week. It's going to focus on management of fungal infections in hematology patients. Goodbye.